Get us started. So, hi, I'm Rebecca. Actually, let me go back. I'm Rebecca Martinez. I'm a nurse practitioner and one of the clinician trainers on the CIAO team. This is, I don't even know how many installments we've had in our CIAO Time webinar series, but today we are focusing on a topic of patient abandonment and the impact of losing access to long-term opioid therapy for patients. This is a new topic for us based on some work we've been doing with the CDC and the Opioid Rapid Response Program. And so we want to just share some patient stories today and some approaches to working with patients who may have been abandoned by the system. Let's see, we'll do a brief review of who we are for those of you who are new to our webinars, what we do at CIAO, and then we're going to walk through a case study, actually 2 particular patients, and these are cases from actually national media, so these are real cases that will go into the impact of a pain specialist's license being suspended. We'll talk a little bit about what we can learn from cases like these, and then we'll move into some resources that we have recently developed, particularly something we've called the Inherited Patients Toolkit. And then towards the end of our time together, we'll do a mock academic detailing visit. A lot of the work we do is academic detailing training, and as a team, we've really been motivated, become a lot more passionate about how to help coach providers through scenarios that at least I, as a provider, used to dread, having a new patient come to me on long-term prescription opioids. And what do you do with a patient at that junction? As a provider, what are some things that can help make that transition both more seamless and safer for patients? And then we hope to leave some time for Q&A at the end. We did want to give a content warning since this presentation today will contain references to suicide, which obviously some individuals, myself included, find distressing. So please do whatever you need to take care of yourself, and we just want to give a heads up about that content coming up. Submit questions in the chat. We'll try to get to questions in the end. You can also raise your hand during the presentation, and if we can get to you, we will. So this is our team here up on the slide. Maybe since we do have a small group today, we can take a minute to just, the folks on our team can unmute and introduce yourselves. So my particular background, I work as a clinician trainer on this team. I also do HIV and Hep C prevention work, and my clinical work currently is in a buprenorphine clinic in San Francisco. I've also done time in primary care, and let me pass the mic to Brian.
Thanks, Rebecca. Hi, everyone. My name is Brian. I'm the CIAO Program Director. And I'll pass it off to Rachel.
Good morning, afternoon. I am Rachel Renton. I'm a nurse practitioner with CIAO. I also work as a research clinician with the Center on Substance Use and Health with Philip. And I will pass the mic to Kat.
Good morning and or good afternoon. My name is Kat. I'm the CIAO Program Assistant, and I'll pass it off to Philip.
Hey, everybody. Philip Coffin. I'm an addiction medicine, infectious disease, and internal medicine physician. And I just want to note Rebecca's terminology that she did time in primary care. Clearly, buprenorphine, being in a buprenorphine clinic is being released for good behavior.
Yes, I chose my terms wisely there. All right, where did my mouse go? I see some intros happening in the chat. Thank you so much. It's nice to have all of you here. So briefly, as CIAO, we are very motivated by the idea of decreasing in any way possible opioid-related morbidity and mortality by promoting balanced approaches to opioid management. Our mission is to collaborate with healthcare providers to improve opioid and chronic pain-related care through training and technical assistance services. If you all have worked with us in the past, you may know we do TA, we do academic detailing training. We've done academic detailing ourselves as a team, and also have created a lot of materials for healthcare providers around overdose prevention and opioid management. We started way back in 2014. Back then, we did some academic detailing projects on naloxone that essentially showed naloxone academic detailing really increases the rates of prescribing in primary care and gets naloxone out. We now do a lot of work both nationally with the CDC and OD2A, and we also work with the California Department of Public Health. Let's launch into our case studies. Rachel.
Hello and good morning again and afternoon. So as Rebecca said, we are discussing some real cases that deal with suicide and potential overdose. And if you can go to the next slide, Rebecca. These are real patients impacted by the suspension of a pain specialist license to prescribe controlled substances. We're not here to pass judgment. We're not going to comment on the prescribing practices of this particular provider who was located in California. We want to focus on the impact of the license suspension, the clinic closure, on 2 of the patients of 240 patients that were impacted by this particular clinic closure. And that's just a drop in the bucket compared to the over 10,000 patients that have been impacted by federal actions. And those individuals were also left without a prescriber in 2022. So again, over 10,000 patients in 2022, and that's just on the federal level. We're not talking about state actions. So there's probably many, many more. We pulled these cases from articles that were published by Vice and the New York Times. Here are the headlines from the Vice articles. And if you go to the next slide, this is the New York Times article. We encourage you to read all of them. There are actually many articles written about the patients that were affected by this clinic closure. The first case we want to discuss is the case of a suicide linked to this particular pain specialist license suspension. His name is Danny Elliott. He was 61 years old. He suffered from migraine-like headaches for over 30 years after being accidentally electrocuted in basically a freak accident, for lack of a better term. He said his pain was like his brain is loose inside his skull. It hurt to blink. His eyes were burning in his head. And that even was the case when he was on pretty high dose opioids to treat his pain. He was eventually prescribed fentanyl, which provided some pain relief. He tried non-opioid strategies as well, like acupuncture. It just didn't touch the pain. Other types of prescription opioids even were not adequate. He was prescribed fentanyl, not by just this particular provider, the one in California, but by previous providers as well. So I think it's worth noting that this provider whose license was suspended inherited this patient from yet another pain specialist who prescribed him fentanyl. The most recent license suspension he was impacted by was in late 2022 in about November. And that was the third time that a clinic closure affected his access to opioid prescriptions since 2018. A week after this most recent license suspension and clinic closure, both he and his wife died by suicide. His wife was not a chronic pain patient, but was his primary caregiver. So I think there's probably a separate presentation we could do on the impact of of these situations on caregivers. Next slide, please. When Danny died, or before Danny died, he sent a note to his brother. And this is one of the quotes that his brother shared with the media. "I just can't live with this severe pain anymore. I don't have any options left. There are millions of chronic pain patients suffering just like me because of the DEA. Nobody cares. I haven't lived without some sort of pain and pain relief meds since 1998, and I considered suicide back then. My wife called 17 doctors this past week looking for some kind of help. The only doctor who agreed to see me refused to help in any way. What am I supposed to do? I think it's important, these clinic closures, it's not just a nuisance to try to find a new provider. The suffering that happens in the in-between time, the opioid withdrawal, the pain rebound, everything is something to consider. And I think it's well illustrated by this quote. Next slide. Another patient who was impacted by this clinic closure was a former nurse, and she's also a chronic pain patient and advocate. Her name is Anne Fuqua. She was a former nurse, as I said, and she suffers from dystonia, which is a condition that causes painful muscle spasms. She also lost her access to controlled substances to opioid pain management when the DEA took action against the clinic. And in response to this clinic closure, she was only provided a list of emergency rooms and a flyer with addiction treatment hotlines. That was the only recourse she was given after being cut off from her prescription opioids. She says her pain went from being pretty well controlled to not controlled at all. And she makes it clear in all the interviews that she gives that she does not want to die. She wants to live. So what can we do to help these patients? And how are patients impacted by these clinic closures and discontinuation of their opioid prescriptions? And I'll pass it off to Rebecca, but if anyone has any comments they want to share or reactions, they're welcome to put it in the chat. You're welcome to unmute yourself and interrupt. But otherwise, I will pass it on to Rebecca to talk about some statistics around suicide prevention, suicide and overdose prevention.
Thank you, Rachel, for recapping those cases. And obviously, these are disturbing cases, and there's so much context as folks who work in healthcare and public health departments that we don't know, and that we wanted to not dive into the weeds because the reality of the impact is very obvious here. We could investigate so many different angles, but really the suffering that was caused for both of these patients and the former patient's spouse as well is very sobering and does cause loss of life, along with just incredible amount of suffering. So we wanted the stories to sort of speak for themselves and provide the context for the rest of our conversation today. So it isn't new information that there is pretty severe morbidity and mortality related to opioid tapering and discontinuation. This image here is from a New England Journal of Medicine article that Dr. Coffin and Anna Lemke wrote a few years back. And I'll just walk us through some of the seminal studies that have shown the harms from opioid tapering and discontinuation that can impact patients, like we just learned about in these news stories. So in this first graph, chart A, this was a study that looked at how opioid tapering and discontinuation impacted opioid use. Illicit, I'm trying to change my language from illicit to non-prescribed opioid use. So this first box here, you can see that there's increased odds of non-prescribed heroin or other opioid pain reliever use after taper or discontinuation for patients. The second study, study B here on the right, showed a high incidence of emergency department visits and hospitalizations following tapering or discontinuing long-term opioid therapy. Down on box C, we also found, well, not we, I was not a part of these studies, but the study found that there was also increased incidence of mental health crises and overdose events compared to patients who were continued on opioids. For the patients who were tapered. And so you can see the patients who are tapered are the darker blue, or sorry, the patients who are continued on their opioids are in darker blue, and the increased incidence is obvious in the lighter blue columns to the right, incidence of mental health crisis and overdose events. And then the final box here, we see that there was an increased hazard ratio, increased risk of death from suicide or overdose for patients who were discontinued on their opioid therapy. And what I really want to point out from this box is you can see that the longer patients had been on their prescribed opioids prior to being discontinued, the higher the probability of suicide or overdose. So the higher risk for death. So for patients on the very, very far right who were on opioids for 400 days or longer, there's a 6.7 times higher probability of death from suicide or overdose. So thinking back to the patients' cases that we just discussed, they had been on opioids for quite some time, and really we should be more concerned when patients are facing a scenario where they can't get their prescriptions refilled, that the overdose risk or suicide risk is higher in those scenarios. There are some other studies that have come out since that New England Journal of Medicine paper was published that really, to me, illustrate that when a patient who's been abandoned for whatever reason, their provider's license was suspended, their clinic shut down, a provider retired, maybe even the system, wasn't able to get them scheduled, and they needed a refill more urgently. The immediate treatment plan should not be to taper. We have seen over and over again in these studies that I just looked at that mandatory opioid tapering for patients who have been on some sort of stable long-term opioid therapy does not reduce short-term harm via suicide, overdose, mental health crisis, or withdrawal. And in fact, it does the opposite. It increases the possibility and the risk of short-term harm. So these two other studies that I wanted to highlight, one from Fenton et al. In 2022, found that for patients experiencing a taper versus patients not tapered, the rate of overdose, withdrawal, or mental health crisis was 1.5 times as high, or higher, I should say, than patients who are not tapered. And for patients who were discontinued or tapered off of their opioids, who had been on a stable long-term prescription without any evidence of misuse, and that piece is important, there was a small absolute increase in the incidence of overdose and suicide events within 1 year. And these were large cohort studies from national data. We'll have the references at the end here. So something that I often think about is we put a lot of energy and funds and campaigning into PDMPs, controlled substance monitoring programs is how we like to call them. But there's no good data actually that using a controlled substance monitoring program or a PDMP really reduces the risk of opioid misuse. However, we pour so much energy into ramping up policies around using these programs without very much data to back them up. And then you come here to the tapering phenomenon, and we have really more than enough data to show that there are harms, and yet there haven't been too many nationwide efforts to get some policies up and running to address this phenomenon that we're facing of patients being really harmed and at risk by inappropriate tapering and discontinuation. So just some food for thought on the comparison between what we're putting a lot of effort into that doesn't have data versus, what are we doing with all of this data that to me as a healthcare provider is very compelling. Going back to these cases and thinking about what not to miss when we either as healthcare providers ourselves take on the care of an abandoned patient, or if you're working in public health or as an academic detailer and you're interfacing with clinicians who may be inheriting patients or seeing patients who have been abandoned by the system, here's some things that we really don't want to miss. Obviously, naloxone prescribing and overdose education and prevention. We always want to have overdose prevention be at the forefront of our thinking when we're working with patients. Harm reduction tools as well. So if there are increased, if there is an increased odds of return to use, non-prescribed opioid use, we want to use our harm reduction tools. So whether this is just the non-judgmental conversations that we have to approach people who use drugs, whether this is something like fentanyl test strips so that people can make sure that they're not being exposed to substances that they don't want to use. Respecting patients and giving them dignity and compassion in a very vulnerable moment is crucial. Also, mental health referrals, since we know that there is this increased incidence of mental health crises. We want to make sure that a patient has the support they need, either through psychiatric medications or therapy referrals or social work, whatever is needed to give that patient some extra help in that transition of care. Other referrals, certainly for buprenorphine, potentially, or methadone maintenance for patients who it's indicated for, maybe a referral to a new pain specialist. And then suicide prevention. You know, for the longest time, I've never really thought about suicide prevention as part of my toolkit and sort of minimum standard of care that I should be providing to patients when they come in and they haven't had a stable provider for a while. Maybe they've just been bouncing back and forth from emergency departments to get their long-term opioid prescription refilled. But really, we don't want to miss the opportunity to sit a patient down and say, hey, this is a really hard transition. You must feel like nobody is taking care of you. How has this impacted you? Have you had any increase in thoughts of harming yourself in any way, or thoughts about ending your life? Is that something you've experienced before? Taking out that toolkit, and many clinics have it integrated into sort of just the baseline questions that patients are asked, but I certainly have been reflecting a lot as we put this presentation together on my own practice, and that really we want patients to have resources and referrals. And sometimes the patient may need extra support and may need to be hospitalized if they're at that point that really suicidal ideation or planning has become more at the forefront because of the amount of suffering that they're experiencing from losing their provider. And just another note on suicide risk. There was a study of suicide decedents, a retrospective cohort that was published from data pulled from the National Violent Death Reporting System that found that more than half of suicide decedents with chronic pain died from firearm-related injuries, and 16.2% died from an opioid overdose. And there's just increasing investigation into whether chronic pain is a risk factor for suicide as well. Both the lived experience of having chronic pain, and these treatment interruptions or patient abandonment scenarios that certainly can put people at pretty high risk as well for suicide. So overall, we want to advocate for increased screening for suicidal thoughts, plans, past attempts, and intent when clinicians are inheriting a new patient. All right, given the magnitude and severity of the risks patients face with the backdrop of the overdose crisis in this country as well, our team has worked with some new partners at OSTHO and the Opioid Rapid Response Program to put together a toolkit for clinicians who may be inheriting patients on long-term opioids. So I wanted to show everyone on this presentation just a little bit of what's featured in the toolkit and how you might be able to use it. So we have a multimedia toolkit, including a video from our very own Dr. Coffin, reviewing steps to support patients who have lost their provider. This is really intended towards other clinicians. And there's a link in the toolkit to watch the video on YouTube. We also have a couple articles written by our team focusing on inherited patients and patients with long-term opioid therapy and some best practices. Oh, and I totally misspoke. The article that I reviewed earlier, the 4 boxes figures from the New England Journal of Medicine, that was not Anna Lemke, that was Antje Barvald. So my apologies for saying the wrong author name. Apologies to Antje if she ever sees this. So we have a couple articles there. We also have a documentation template to be used in a charting scenario for patients who are on opioids for chronic pain. An example smart phrase for Epic for providers who may use Epic as their electronic medical record. We have an example policy on managing inherited patients and an example letter to clinicians that can be sent out within health systems, really advocating for continuity of care for patients who are treated with buprenorphine for opioid use disorder as well, in the context of the new DEA changes to the buprenorphine waiver. This is our documentation template here. So you can see we really put a lot of effort into making this as short and sweet as possible. So we really suggest the components of documentation over on the left-hand side, really a pain history, any other relevant history, pain assessment, physical exam, risk factors, etc., all the way through the plan to have a really thorough note about decision-making about patients who are on long-term opioid therapy. This is intended to also be converted into like Epic smart phrases. So we have this, and then we also have an example of a patient and how the note might look with all of this filled out. So you can take a look, and hopefully, if it's not already in the chat, we can put the link to our Inherited Patients Toolkit in the chat so folks can pull this up as we're looking at it. Obviously, there's a lot here, and as a clinician myself, it's very hard to check all these boxes, but really this is intended to be both a thorough note so that we don't miss anything when we're working with patients for the first time, and also to provide the medical justification for continuing a patient's opioid therapy, for instance, the first time we see them, you know, including rationale in treatment planning, and notes is really critical for protecting one's license. Aha, I have some animation in this slide. So our example policy includes some sample language as well that can be used in a clinical visit. So we have a couple sound bites here that are intended to be patient-centered and also set some expectations for providers, or for not providers, for patients who may be meeting a provider for the first time. For example, you know, on transitioning care, acknowledging it's tough to transition from a provider who knows you to a new provider who's not familiar with you at all. At this first visit, I want to focus on getting to know you and refilling whatever prescriptions you may need. In the future, we'll come up with a plan of care together. Often that first visit can be, you know, like a stalemate on both sides. And the new clinician meeting a patient for the first time is like, this is how things need to be done in my practice. And the patient says, well, this is how things have been done the last 10 years that I've been working with this other clinician. Why do things have to change now? And hopefully this is a middle ground. So there's the sample language, and here's a screenshot as well from the video that I mentioned, this 5-minute video with Dr. Coffin talking about how to care for patients at that crucial transition as they're trying to find a new provider. Also, a pitch here for the Substance Use Warm Line, which is a national service for peer-to-peer warm line support for clinicians who need help, maybe at that moment of evaluating a patient and not feeling comfortable, for instance, with the morphine milligram equivalents that a patient is on. And what do you do at that first visit? How do you make sure that the patient is safe? How do you make decisions around substance use disorder diagnosis, or when a handoff to a higher level of care is indicated? So I've worked closely with this team. I have been on this team before and still work closely with them. And they're just a super valuable resource for any providers who struggle. I know I struggle every time I inherit a patient. So this is an additional safety net for clinicians. To sort of recap what we've talked about, and I feel like we're really just scratching the surface on this issue. We could probably talk about this for like, a whole weekend conference, but patient abandonment is a national problem. And thankfully, the CDC and Health and Human Services are really trying to find ways to address this and make sure that patients are not left stranded after their providers, for whatever reason, cannot continue prescribing. There are very significant risks of morbidity and mortality when patients don't have their stable long-term opioid prescription refilled during these transitions in care. And we talked about the risks from mental health crisis to hospitalization and overdose and death, including from suicide. We want to prevent suicide risk and overdose risk. Well, there is overdose risk and suicide risk, so we want to prevent those things from happening when we take on the care of a patient who has been abandoned. And consider using some new communication tools, whether it's a clinic policy, documentation templates, to standardize approaches to caring for patients who have been abandoned. And really, whatever role you have working in our healthcare system, I think there's a lot of room here for advocacy, that patients are treated with respect and dignity and are not continued to be, that we don't continue to abandon them in that moment, that we can intervene and support them and come alongside them and figure out what they need to thrive and be safe. So with that, I haven't been paying attention to the chat. Are there any questions coming up in the chat that are worth talking about? Oh yes, thank you for the Suicide and Crisis Lifeline. Laura Welder, thank you so much. Any other questions that haven't been addressed yet? Otherwise, we'll move to our academic detailing demonstration. Okay. So what we're going to do now, I'm going to actually, let me go to this next slide. So I'm not sure if everyone here is familiar with academic detailing. It is a one-on-one educational collaborative session that is intended to move from a needs assessment with a clinician. So the academic detailer really always comes in with open-ended questions to try to see how they can collaborate with the clinician and address some of the struggles that clinicians are having. And I've just put the steps of a visit up here so that folks can sort of be oriented to what typically happens during an academic detailing visit. This example session is going to be structured around patient abandonment, but you may be able to follow through. There will be an introduction, a needs assessment, some sharing of key messages, and obviously handling any objections, and moving towards a summary and close, which typically involves some sort of behavior change. That's the goal of academic detailing, is to encourage behavior change among clinicians being detailed. So let me stop sharing my screen. How we usually do this on our webinars is a lot of you are already off camera, but for those of you who are on camera, we'll ask you to turn off your camera so that the folks doing the mock detailing session can be front and center in your screen, and so that they're not distracted by what the rest of us are doing. So I'm going to turn off my video, and thanks to Rachel and Philip for doing the demonstration today.
Thank you, Rebecca.
So we'll just go ahead and get started.
Yeah, ready when you are.
Hi, Rachel. It's a pleasure to meet with you. Thanks for taking the time today.
Of course. Thank you, Dr. Coffin.
As we discussed on the phone, I'm going around talking to providers about opioid management, not the simplest issue, but I do want to make sure I respect your time. So how much time do we have?
Oh, I have about 10 or 15 minutes before I start seeing patients again.
All right, I'm going to set a little reminder so
Thanks.
that I don't go excessively over. I'll set it for 15. I'll set it for 15 minutes. Maybe we'll get done sooner.
That's perfect. Okay.
My first question to you is, what kind of issues do you have around opioid management in relation to chronic pain or addiction, anything like that in your practice?
Oh, what problems don't I have right now? So I've been in this primary care practice as a nurse practitioner for a few years now. And just recently, a doc within the same healthcare system has retired. And turns out he had a lot of patients that were on opioids. And we're kind of, sharing the burden of taking on those patients across the clinic. And I've had a few kind of difficult cases trickle in the last few weeks. Folks that are still on their opioids, or actually a couple that have been off them completely, and so they've gone through withdrawal. They're pretty unhappy with their situation, and I just struggle with knowing what is the next step, because it seems so complicated and risky for both, for me and for the patient.
Wow, thank you so much for bringing this up. The first thing I want to say is, well, first, obviously, thanks for doing what you do. It's such important work, and it's great to have people who really care out there. Second, you're not alone. This is probably a national crisis, and it's happening to patients all over the place. And providers. In my own practice, it's a routine event to be inheriting patients that, oftentimes I don't agree with the opioids that they're on. I wouldn't have started them. And it's hard to jive that with the way I would have taken care of the patient had I been caring them for them for the past 10 or 20 years. I would love to chat with you. I've definitely got some resources to share with you. But first, could you tell me maybe about more details about one or two of the cases?
Oh, sure. There's one case in particular that was challenging. A woman that I saw a week or two ago, who is about 60 years old and had a stroke about 10 years ago, and was started on opioids for pain management for hemiplegic shoulder pain that was really increasing in severity in the months, post CBA. She had been on, various tapering programs in the past, but she's still doing about 30 milligram hydrocodone BID. And when this doc retired, she started running out of her prescription. She was trying to stretch it out. She was, borrowing her neighbors. And right now I'm at this impasse where I have to decide if I'm going to renew that prescription, or since she's almost done with it anyway, let it take its course. She's kind of gone through the worst of it. I'm at a loss. I don't know if I should refer her to a pain specialist, or really what to do, what the next step is.
Oh, that's great. Do you, sorry, that's not great. It's a terrible situation, but
Right.
it's right in line with, I think, arguably the most important issue in this domain right now. And do you have, is there a clinic policy or anything like that? What is the, what restrictions are you working within?
Right. Well, the clinic policy has not really been updated. It's still pretty hard line, you have to start tapering patients. And any mentorship I get from some of the doctors that have been around or, knew that retiring provider, they all sort of are pretty hardlined about it too. They inherit someone, they start tapering right away.
Okay. All right. And tell me about your first meeting with this patient. How did it go?
Not great. I don't think either of us felt good by the end of it. She's suffering. She wants to get her pain meds back. I did not renew the prescription after that appointment, and she said she was going to go to the ED to see what she could get there.
Okay. And do you mind if I share something with you?
Please, yeah.
So we have a set of resources around exactly this issue, inheriting patients that are already on long-term opioids. And I'd love to point you to a few of those things. The first thing I want to share with you, though, is actually something that we have a policy, a draft template policy that clinics could have around inheriting patients. And I wonder if this might be something that you might want to talk with your clinic leadership about.
Yes, absolutely.
Because it's different from, I think, what clinics have been doing for a while. Specifically, what we're doing here, the purpose, I don't usually present a bunch of text on a shared screen. Forgive me, but what we're trying to do is balance patient safety and well-being with clinicians, frankly, being able to safeguard their practice. Because what we're all worried about is losing our license, getting investigated, risk management issues. And that's plus patient safety. And sometimes those are conflicting a little bit because patient safety is often about not having radical transitions in care. I think you know this from what you've said. I think you've probably seen some of the data around the hazards of stopping opioids, tapering, and abruptly stopping opioids. So,
and this particular patient was certainly in crisis.
So we don't want to do that. We don't want to put people in crisis. Obviously, if we can avoid it, it's really important. So the point of this, we drafted this, and the policy has sort of 3 points. The first is making sure patients don't get cut off from opioids that they're physiologically dependent on. So if they're taking 5 milligrams of Vicodin every 2 or 3 days, it's not critical that they get that refilled immediately because they're not taking it every day. If they're taking the doses that you're talking about, 30 milligrams twice a day, that's enough for physiologic dependence. And so we know when you cut people off from that, the withdrawal, the stress, the pain exacerbations, all that stuff can lead to really bad outcomes and frankly, death in many cases. And the next thing is to make sure that we're basing things on evidence. We're screening people for opioid use disorder. And if we're going to do tapers, which we don't always have to do, they're not always appropriate. And I know it's really hard to it's really hard to get there in the current context. But if you're doing it, then you're doing it in a patient-centered way, which meaning that you are you're working with the patient. And I'll tell you, we can talk a little bit more about what a patient-centered taper looks like. And then finally, we want to make sure they stay engaged in primary care, right? Is your clinic, are you kind of a safety net clinic, or are your patients all well insured and can go anywhere?
We're more of a safety net clinic, which makes it harder to know in this particular case, is this a job, is it worth referring and making this person wait however many months it takes to get her into pain management? what can I do in primary care? I just don't know.
Yeah, exactly. I mean, we know in safety net clinics, keeping somebody engaged is really critical to their well-being. So, so that's, you're the last line of defense for somebody that's being abandoned. So here's what we put into the procedure section. Number one is, establishing rapport with the patient, not getting into that conflict right out of the gate. And that's hard, and refilling the patient's prescriptions. And this means opioids and benzodiazepines, which I know goes against what everyone's telling you and what all the regulators are telling you, unless you've got life-threatening safety issues. And this is actually concordant with the 2022 updated CDC opioid prescribing guidelines.
Right.
You're not supposed to change things right out of the gate unless you've got a really good reason to. And a longstanding policy that about, protecting our license rather than protecting patient safety isn't a good reason.
Right.
I know that's hard to say.
Yeah.
And then, initiate the referrals. If they need a pain management referral, if you're going to need, which sounds like you probably are, kickstart it. But you got to take care of them in the meantime and not make them wait, unfortunately. Hey, am I talking about something that you could never achieve at your clinic? Or is this something you think you might be able to do?
I think my clinic certainly needs to put some effort into updating their policies to being more current with the CDC recommendations. I think referring this particular patient to pain management is appropriate, but what can I do in the meantime? I feel like at this point, renewing her opioid prescription isn't the right call, but if not renewing her hydrocodone, then what is my next step?
Is there, how much would you say she's taking at this point?
It's hard to say. It was a little guarded in providing history around that, but she said she was stretching out the prescription that she had left and borrowing when she can. She lost access to that prescription about 2 months ago when that provider retired. So
you don't feel like you could refill any opioid for her?
I could, I'd have to push back against my clinic policy a little bit.
Yeah. So,
yeah, I feel stuck. I guess is what I'm trying to say.
It might be the right thing to push back against the clinic policy a little bit.
Yeah. I think you're right.
Sounds like that might be the right move. The other thing I want to throw out there is, the most important thing about this is for your license protection is making sure you document things. The vast majority of actions taken against providers are justified based on insufficient documentation.
It's a good reminder.
And making sure you document everything you can think of in this domain. We have a nice list, and we actually have an Epic template. I can send you.
That's great. Please.
Our smart phrase template for Epic, if that's your EMR. It's pretty extensive, but if you're really worried about, if you're doing something that you feel like is against clinic policy or, outside of what you understand the guidelines to be, documentation is where you protect yourself. And, you do a good documentation of the pain history. You make sure you do opioid use disorder screening with the DSM-5, really easy and really useful. Send your urine drug screen, do your controlled substance agreement or some kind of informed consent documentation, check the prescription drug monitoring program, make sure they have naloxone, and then in your plan, justify what you're doing and say, because of all the data showing overdose and suicide risk, I don't feel it's safe to not refill this patient's medications during this period of transition while I get to know them and can work on a patient-centered plan forward.
Thank you. That's such a good reminder. because it's a huge drive, is a self-preservation instinct. But it's a good reminder that just documenting my logic behind it can be protective for both of us, myself and the patient.
Yeah, I think it's really important. And, if you ever were, God forbid, investigated, if you have a plan and that plan is pointing in what regulators see as the right direction, then you're in pretty good shape. And these tapers. So I promised I'd talk to you about a patient-centered taper plan. What do you think about that? What would that? Can you think of how that would look for you?
Yeah. I guess the first step being actually renewing that prescription, with the understanding that we are going to have a conversation about what this will look like going forward. But certainly, I know there are recommendations in terms of percentages we should drop the opioid dose. But I think working with her and really figuring out how this is helping her pain is the best course. Those are my initial thoughts.
Oh yeah, that's great. That was brilliant. Yeah, I think the first question I love to ask somebody is, whoops, that's our time. I ran out of time. I'm so sorry. I need to wrap this up and let you go. So everything we talked about, what's your next step going to be?
Well, I want to get this patient back in, certainly, see if I can salvage our rapport, our relationship, and just take care of her better. Do better by her.
Okay. All right. So I'm going to send you the stuff I showed you today,
Great.
as well as the Epic Smart template. And any chance we could meet again in maybe 3 or 4 weeks?
That would be great. And I'll probably see her in the meantime, so I'll have more to talk to you about.
Excellent. Thank you so much. Thanks so much for taking the time. And thanks again for your compassion and care of our patients in need.
Likewise. Thanks for your time.
And scene. How did that feel?
It felt good. I felt like you had a lot of compassion for my position as well as the patients, and understanding where I was coming from, just all the fears that providers have around prescribing opioids in general. And for you?
It felt good. You were easy to talk to. I do feel like you're in a tough situation, as a nurse practitioner in a clinic with a clinic policy that constrains you, and other, maybe senior providers that constrain your decisions as well. Puts you in a difficult position, which is why I chose to focus on the clinic policy document as a potential template that could influence your clinic policy, which could allow you to practice more patient-centered medicine.
Right. That's a very real lived experience. And just being given permission to push back and, not do my own thing completely and flout the rules and all that, but just to really push back and take care of the patient the way they should be. I think that's what a lot of providers need in these situations, that permission.
I love the note in the chat as well about just respecting providers' time with the timer. Nice illustration of that academic detailing. Bottom line, to always time visits and be respectful. Any comments from our, I want to say audience, not really an audience, from our webinar participants on what was noticed or liked, or any other ideas folks had from the academic detailing demonstration? And if not, we can just move into a Q&A more broadly. And since we are a small group, please feel free to unmute yourselves. We'd love to say hi and find out a little more of your context. And we're really motivated by actually getting real interaction on these webinars. So yeah, Arthur.
Hi, I was wondering if Dr. Coffin has a set of points that he has, kind of like a prompt script that he goes through in order to guide the conversation, or does he go based on the responses only?
Oh, that's a great question. I go based on the responses and the sort of tools and agenda that I have. In detailing somebody, I like to have a broad enough repertoire of issues that I'm going to address that I'm not trying to fit a square peg in a round hole. So, if I only have, let's say if I was only detailing on naloxone, and I saw a provider who issues naloxone to everybody, well, what else can I talk about? Or a provider who's like, no, I never do that. It's terrible and I'm never going to. Then what am I going to talk about? It's good to have more than one domain to fall into. In this particular case, I knew Rachel was going to present me with a provider, with a patient who had lost access to opioids, given the theme of today's talk. And I know the resources that we have available, as I helped to create them. And I pretty quickly, in hearing her talk, felt that her main constraint was the clinic policy and the providers that she works with. And I felt like just the information wasn't going to change that, wasn't going to affect that constraint. So I went to the policy document, I went to the resource that I thought would be most helpful for that, recognizing that, yeah, she might not be able to provide opioids to this person, this abandoned patient in desperate need of continuity of care. But maybe she can change things so the next patient she can take care of appropriately. And so I shifted in my mind to a somewhat of a long game in that case. And but I never go into these detailing, even these mock detailings, I never go into them with a laid out agenda or set of talking points.
And is that do you think that's more fruitful, as opposed to, or do you just, because you're so experienced at doing this, you don't need one, but someone like me who's maybe just starting out with the academic detailing, I guess I'm getting at, would it be helpful for me to have those, or should I just go by those responses that the provider gives?
Again, excellent. One of the things we do in our training is we have people come up with issues that may arise on a particular topic and ways that they can respond to that. So it is really useful to have, I'm backtracking now completely, my apologies. It is really useful to have that sort of set of talking points and to really kind of work out how you're going to respond to different barriers. So for example, with naloxone, it's pretty accepted today, but back in the day when we were doing this, some of the barriers would be, my patients aren't at risk for overdose. And so a response to that is that, we don't always prescribe it for the patient. Sometimes we're prescribing it for a risky drug that somebody else might get access to. Some of your patients may have family or children or grandchildren in the house, and they may access these medications. So we want that reversal agent on hand there. And so having those kind of responses is really useful. We try to include the data to support most of the responses we're looking for in our guidebook on opioid prescribing that's available on the website, and at ciaosf.org. And we pick our data for this document based on what we think are likely barriers to this issue to a given issue for a provider. So yeah, absolutely, having talking points is great. And I apologize for my first answer.
All right, thank you.
I mean, I will say, just, I do in reality inherit patients on high dose opioids most clinic sessions that I start in, and I'm very outspoken on this topic, and I'm in California, where the medical board is pretty aggressive, and there have been a lot of pursuits against providers, even just for prescribing, let's say, opioids and benzodiazepines at the same time, even when there haven't been bad outcomes for the patients. And so I am kind of paranoid. When I inherit these patients, I sweat. I worry about it. And I obsessively document. It takes a lot of time. It eats a lot of my time. And that's the one piece I don't have a fix for. My fix for making sure patients get appropriate care is to spend more time than I have documenting the care decisions. And I don't have a workaround for the time. It's a sacrifice that you have to make in order to try to protect patients in vulnerable situations. I wish I had a workaround for that. Other things I'd rather do with my time than sit in front of Epic documenting things for an hour.
Just a plug for our templates that are on the website to maybe hopefully ease that burden for some folks. Create smart phrases. You can fill in the blanks that are patient-centered, or on a case-by-case basis, rather.
This is such a rich discussion. And I love how it's really centered around academic detailing. I really noticed, Philip, a lot of motivational interviewing techniques as well in that session. I think that they come more naturally the more we practice them. So motivational interviewing is definitely a phenomenal tool to use in detailing sessions. It really helps the provider feel like they're the ultimate decision maker, and we're not shoving an agenda down their throats to take on every single inherited patient and prescribe everything to them. It's really more of a come alongside and problem solve together approach. So